in terms of how we treat ovarian cancer patients. We tend to use the same primary backbone of a platinum with a taxane, and that actually changed while I was early in training. And so that's been pretty much the backbone of our treatments throughout the course of my career. What we've really done, though, is seen a number of new agents come online whose combined contribution of progression-free survival, I think, has contributed to an overall survival benefit. So if we look 20 plus years ago, many of these patients that had advanced disease were living in the neighborhood of a little over 2 years. We then saw that extended out over 3 years with the taxanes, and now we see patients who were able to get to small volume or no gross disease at primary cytoreduction living out over 5 years in terms of median survival. So while we're not curing a lot more women with ovarian cancer, we are getting these patients to live for a longer period of time, and I would argue with a better quality of life as well. I think that that's been something I've seen as well in terms of we've looked at schedules, we've looked at dosing, we've looked at sequencing, and as well as support during treatment, and we've been able to get patients through these treatments with less lingering quality of life issues, and that's really important. The recent approval of Bevacizumab has been very welcomed by the treating community because it gives us more options. And so with having the ability then with platinum-sensitive disease to incorporate Bevacizumab, it gives us the ability to put an active agent further up in the treatment line, which I think is very appealing. It also helps us address why the patient's being treated. In other words, if the patient's symptomatic, if she has pleural effusions, ascites, all these types of hallmarks of markers for potential Bevacizumab response, it gives us more in the way of a larger menu to choose from, and I think it helps us more precisely sequence these agents as we go through treatment. The approval of Bevacizumab in the platinum-sensitive space has been based on 2 large phase 3 trials. The first trial is GOG 213. This trial looked at taking patients in a bifactorial design through 2 decision points. The first one, is the patient a candidate for surgery for secondary cytoreduction? So these are platinum-sensitive patients, again, recurring out over 6 months from the time of their initial platinum. These patients were then randomized if they were surgical candidates to surgery or not having surgery. And then there was a secondary randomization between carboplatin and paclitaxel with or without the administration of Bevacizumab. So they were randomized to either receive Bev with the carbopaclitaxel backbone or not. Carboplatin was administered at an AUC of 5. The paclitaxel was administered at 175 milligrams per meter squared, and the Bevacizumab was given at 15 milligrams per kilogram. They found that there was an improvement in overall survival that was approximately 42.6 versus 37.3 months in terms of the medians. The hazard ratio was 0.84 or 0.82, depending on how it was calculated, and that achieved barely statistical significance when you did the one based off the electronic case report forms. So this was a very important study because we actually have now an improvement of almost 5 months in overall survival, which is very welcome. The other thing that's really important to point out is that you had a higher response rate as well, so about 78% versus 57%. The second phase 3 trial was an older trial, but it looked at carboplatin and gemcitabine. Carboplatin was given in an AUC of 4, the gemcitabine was given in 1,000 milligrams per meter squared, combined with Bevacizumab in the same dose as the GOG 213 trial. So the Oceans trial was with gemcitabine, and what we found was there was an improvement in progression-free survival of about 4 months. Again, we saw the same increase in response rate, so about 56% all the way up to 78% when you added the Bevacizumab. So very positive data. If you look at the hazard ratio for the primary endpoint, it was 0.46, so a very large benefit to receiving the Bevacizumab in this case. Both of these trials are interesting because the bevacizumab was continued until disease progression or until toxicity. So I think in terms of how do you administer the bevacizumab, the advice would be to continue therapy until either of those two endpoints occur.